Last time, if you remember, Peter Morgenstern gave a stellar intro. Unfortunately, he had to go to another meeting, so I'm gonna give a shot at it. So here we go. Ladies and gentlemen, residents and attendings, put down your attractors and move your Instagram feeds to the background because today at Neurosurgery Grand Rounds, we bring you a no holds barred, cerebral showdown in the spinal surgery arena. In one corner, striding in from Puma sponsored elite finishing shoot of the London Marathon with a time of 2 hours and 28 minutes, faster than our average OR turnover time. He slices and dices. He believes no spine should ever be fused. It's the poster child of posterior approaches, the laminoplasty luminary himself, Alex, the pronghorn antelope Schupper. And in the other corner, fresh from a relaxing white rotation, clutching his annotated copy of Greenberg and fueled by caffeine and pure determination, he's the champion of constructs, the king of cages, the fusion-forward philosopher himself, Abi, the pedicle finder, Bhimani. Today's main event, point-counterpoint laminoplasty versus laminectomy, infusion for degenerative cervical myelopathy. One believes motion is preservation, the other believes motion is liability, and reimbursement is virtue. Only one will walk away with their surgical dogma intact. Let the battle of evidence, ego, and instrumented constructs begin. All right, take it away.
All right. Yeah, I will get started. Thank you for the introduction, Dr. Keller. Okay. So we're gonna discuss about cervical fusion versus laminoplasty, and I have chosen the point of view from PCDF perspective. We're going to go through the several reasons why I believe that a posterior cervical instrumentation and fusion is a superior alternative, or just an overall superior surgery compared to a laminoplasty. And my colleague, Dr. Schupper, will argue otherwise. Brief details, cervical spondylotic myelopathy, progressive degenerative condition requiring spinal or resulting in spinal cord compression from spondylosis due to a variety of causes, as we already know. The pathophysiology involves static as well as dynamic mechanical forces, which comes into play when choosing the best approach for this pathology. There's also a literature on potential microischemia from the vascular compression due to the spondylosis, also contributing to the myelopathy. The clinical spectrum can vary wildly. It's including neck pain from sensory issues all the way down to significant motor weakness and in rare cases, paraplegia as well, along with bladder dysfunction. This is a picture that summarizes it overall, that there's not just a single cause for cervical spondylosis or cervical spondylotic myelopathy or myeloradiculopathy. A lot of the adjacent diseases. They include, ossified ligaments from retrolisthesis, enterolithesis, disc herniation, and a pseudodisc, bony osteophytes, and also a lot of times ligamentum flavum, and ossification of posterior longitudinal ligament, which can contribute that. So I just wanted to start off by remembering a quote from my chief when I was an intern. This was my first, my first year. I was at Elmhurst, and this is the quote I heard repeatedly: that I only offer 3 surgeries to my patients: C2 to T2, T10 to pelvis, and eventually T2 to T10. I'm not as aggressive, but I am going to argue from Dr. Yuke's perspective today. So the surgical goals and the posterior approaches, including laminoplasty as well as PCDF, primarily the posterior cervical fusion has a surgical goal of not only decompression of the spinal cord, but restoration of physiological and cervical lordosis, as well as a stabilization of the cervical spine stability being most important. This picture here illustrates in general the technique where you're doing this full laminectomy, full wide laminectomy, and doing a posterior lateral fusion um, along with the autograft and allograft to solidify the instrumentation into the fusion over time. Um, the two posterior options we're going to be discussing would be a laminoplasty and PCDF, and my presentation will advocate for the PCDF in specific clinical scenarios, emphasizing most states biomechanical stability and prevention of cervical kyphosis. So overall, this technique involves the arthrodesis of two or more cervical vertebrae using a bone graft as well as instrumentation. The mechanism of stability results from the solid bony bridge at the lateral mass in the cervical spine. The instrumentation provides an immediate stability, and the long-term stability is provided by the fusion that eventually happens at that level. It is and a good fusion is crucial to prevent postoperative instability. This is especially important in multi-level decompression, where before the instrumentation was common, posterior cervical instrumentation was common. Um, I think a lot of our elderly attendings would remember that they would only do laminectomies in the cervical spine. And yeah, these approaches were partly implemented to address the potential instability from those laminectomies. The early instrumentation evolution started with wiring techniques that offer some limited stability, primarily in flexion distraction. And the lateral mass screws, from C3 to C7, also the pedicle screw at C7. The lateral mass would provide a better fixation in at least the subaxial spine, and the pedicle screw at C2 and C7 can also provide even a stronger stability and a higher pull-out strength for a longer construct. Um, Briefly on laminoplasty, I'm sure Alex is going to explain, go in much more details, but it was developed in Japan to overcome the drawbacks of laminectomy. This was not initially developed to overcome the drawback of posterior cervical fusion. The claim benefit mostly was compared to a standalone laminectomy, and in which it preserves the posterior elements to reduce the post-laminectomy kyphosis. It's used for multi-level decompression and spinal canal expansion, and I think it's the best for motion preservation in individuals who have conjunctively narrow spinal canal without a significant neck pain or biomechanical instability, which is basically 1 in 100 patients we see, at least at Mount Sinai, based on our population in the ED. So let's talk about prevention of cervical kyphosis with importance of fusion. There is lordosis is important to maintain natural cervical alignment, and it's vital for biomechanics and neurological function. Um, and the cervical laminoplasty, as well as the prior just standalone laminectomies can have a risk of postoperative kyphosis, um, which the posterior cervical decompression and fusion, allows you to fuse the patient in a lordotic segment, preventing or even correcting the kyphosis that has already happened. It maintains your sagittal alignments for better long-term biomechanics. Let's talk about some of the reasons why laminoplasty is not always the right answer. Right? There is some data that you can have recurrent stenosis after laminoplasty. The potential concern for laminoplasty reclosure um, um, after the lamina have been expanded. There was a study that found approximately 10% decrease in the AP diameter and the opening angle after 6 months of laminoplasty. Fusion stability, as well as kyphosis prevention can actually protect it for future neurological decline that you can see with laminectomy and laminoplasty. So we're gonna go through some of these pictures. So one of the other potential issues is concern for inadequate decompression. A lot of the patients who have a multi-level anterior disease You can do a 7-level ACDF. Dr. Chaudhry and Dr. Hooton may be able to pull that off, but a posterior option of laminoplasty is not appropriate for this severe degree of an OPLL, and there's multiple studies supporting this. There's a Japanese study for 22,000 patients showing that the complication, postoperative complication rates on laminoplasties with severe OPLL was higher than those without. That they actually also had an increased cost of hospital stay in that laminoplasty group. There was also another study that studied 29 patients started post-laminoplasty and followed them radiographically, which showed almost 71% had greater than 2 millimeter OPLL progression um, in 5 years. So because it doesn't fuse the patient, sometimes it does not prevent worsening of these spondylitic changes. Other issue, and this is a classic MRI we see like twice a week at Mount Sinai emergency room, right? There is issue of for inadequate decompression, especially in a patient with myeloradiculopathy. Since there's a lack of instrumentation, it can limit the extent of the foraminectomies and facetectomies you do to achieve adequate decompression of the foramina. Um, there's also an argument, against PCDF that they use, saying that there's an increased risk of a C5 palsy compared to laminoplasty. However, there are ways to prevent that include the foraminectomies, which can easily be done given the nature of the PCDF surgery. The other concern is the axial neck pain. There's a significant prevalence of a post-laminoplasty axial neck pain compared to PCDF, and it can limit the range of motion because of the pain. So the whole motion preservation argument of laminoplasty has to be taken with an asterisk, because if you can't move your neck because you develop new pain after laminoplasty that you didn't have before, then may have just might as well just get a posterior cervical fusion and all the benefits that come with it. And uh, this is an example of, say, some severe cases and also trauma cases where you have significant spondylolisthesis, anterolisthesis, uh, as well as concern for acute spinal cord injury that would need a very strong constructs. So obviously, this is a case that laminoplasty would not be appropriate because you're looking to fuse this patient 360 degrees. Um, I just showed this picture because we have to know when the studies compare laminoplasty to posterior cervical, all these cases, posterior cervical fusion is used successfully. So, there's still a majority of the population that does not benefit from laminoplasty. So it is not an alternative technique to PCDF. Now, and there would be a cost argument for laminoplasty. A lot of the companies will make you say that, oh, laminoplasty is more cost effective for it, which is true. However, given the significantly limited indications, if a laminoplasty fails, like you can see in this example, and you need PCDF after that, you're basically just increasing the total cost of the treatments. So you're basically increasing the cost by 1.5. If you don't choose the patient properly, when you could have just done a posterior cervical. All right, so these are my overall impressions before I give it to Schupper. Severe OPLL, not a great indication for laminoplasty. Axial neck pain, also not a great indication. Dynamic instability, not a good indication for laminoplasty. And for trauma, no, also a hard pass. And PCDF would be indicated for all of the above. So my argument is that PCDF can be offered as an alternative to most patients that are candidate for laminoplasty. So for all the arguments, for laminoplasty versus posterior cervical, you can think of it that way. If somebody's a candidate for laminoplasty and you do a posterior cervical instrumentation infusion, for 99% of the time, it's okay. But you can't say that same thing the other way around that most patients undergoing PCDF would be a candidate for laminoplasty. So one is an appropriate tool in your surgeon's toolbox for specific indications. However, although it's a specialized tool, PCDF can be seen as a master key that can treat a wide variety of patients. Thank you. And Alex will present his side of the argument, which is equally, if not even more convincing.
Thank you, Abhi. Share my screen. Oh, okay. Thank you, CPK, for the humbling intro. All right. So pushing the limits on motion preservation in laminoplasty for degenerative cervical myelopathy. I personally have no relevant disclosures. However, as CPK alluded to, Abhi, the pedicle finder Bhimani, has been obsessed with putting in screws since medical school. Photo evidence on social media below. Take that with a grain of salt. So some objectives for today is, first, we're going to define degenerative cervical myelopathy. We're going to go into the indications as well as contraindications for laminoplasty, talking about the 5 major advantages laminoplasty has over lami fusion, and then we'll conclude with some take-home points. So I think Abhi did a really nice job outlining what cervical myelopathy is, so I won't belabor the point. It was previously referred to as CSM, but in more recent literature has been retitled degenerative cervical myelopathy, which is a more encompassing term. It's defined as spinal cord dysfunction due to compressive pathology within the cervical spine. As Abhi mentioned, a wide range of symptoms, going from extremity pain or numbness to impaired coordination, bowel bladder dysfunction, etc. There are many causes, as Abhi mentioned, from disc herniation, ligamentous hypertrophy or ossification, osteophyte pathology, etc. There are many indications for cervical myelopathy. Clinical presentation, I think, is always the most important, alluding to Dr. Miranda's talk. Progression of symptoms, especially in the context of myelopathy, is incredibly important. Moderate to severe myelopathy, I think most surgeons would agree, is a definitive indication for surgery. If you look back at the literature, even 20 years ago, surgeons recommended not operating on myelopathic patients until they were myelopathic for over 6 months, actually. You can read Law's paper from '93. However, I think the current consensus is that we often try to treat myelopathy on a sooner time frame, which I think for most patients is clinically appropriate. Myelopathy is a relative indication. There's less consensus on patients with very mild symptoms. This is still up for debate. And then radiographic considerations are incredibly important, which is the focus of today's topic, largely in radiographic considerations that determine which procedure is most appropriate for patients. The patients with severe spinal cord compression, definitely an indication for surgery in many cases if the clinical presentation aligns. Patients with myelomalacia or other evidence of spinal cord injury. And then this is not used as commonly, but the torque-Pavlov ratio of less than 0.8 confers congenital stenosis, which is often an indication we use, especially in the context of laminoplasty. So I think in terms of outlining what the indications for surgery for CSM are, we really have to understand the goals, right, and what we're hoping to accomplish. And I think this will allude to what the most appropriate procedure is for this disease. The primary goal is always prevent progression of the disease via decompression of the neural elements. And then the secondary goal really depends on the individual patient. I think this is the focus of today's counterpoint. In determining whether motion preservation or segmental stabilization is important really depends on what the patient has as far as pathology. And then if the patient has deformity that needs to be corrected, which I think Abhi and I can both agree fusion is the most appropriate treatment in these patients. Now, in terms of the surgical management, I won't spend too long on this, but there are anterior approaches, as Abhi mentioned, posterior approaches, which Abhi and I are both speaking about today, which include laminectomy plus minus instrumented fusion. The laminectomy alone is more of an old school approach, as not as commonly used in myelopathy, at least not seen as commonly today in our practice. Laminoplasty, and then a hybrid fusion motion preservation surgery, which has unique context that's appropriate for. And then there are also obviously combined anterior and posterior approaches, which Abhi mentioned. So in terms of laminoplasty versus laminoplasty infusion, I think like anything in spine, as Jeremy Steinberger always says, indications, indications, indications. I think if there's one take home from this debate, it's that indications are everything in spine, but especially in this topic. And then as I'll go into in the next few slides, there are many advantages that you'll see that laminoplasty has over laminectomy infusion. And echoing off the historical perspective brought up by Dr. Miranda, I think it's really important to understand where laminoplasty came from to understand the indication for it and why it's used in today's practice. So as Abi mentioned, it was originally developed in Japan, and the problem that Japanese spine surgeons in the 60s were trying to solve is that they realized that a large population of middle-aged to elderly Japanese men had OPLL, and the standard of care at that time was just to do laminectomy alone. And as Abi mentioned, laminectomy is a very effective procedure for OPLL in the short term, right? It decompresses the neural elements well. However, what these surgeons realize is that these patients almost always kyphose over, which leads to very severe problems in the setting of OPLL. So they wanted to refine this technique to provide some stabilization in terms of preventing these patients from kyphosing over after decompressing their spinal cords. So Miyazaki and Korea were the first ones to introduce the idea of laminoplasty back in the 60s. There have been a slew of prominent Japanese spine surgeons over the past 50 years, or even 60 years now, who have really revolutionized the topic. Bhimani and Hattori in the 70s described the Z-shaped laminoplasty, where they thin out the bottom of the lamina in a Z-shaped maneuver to really preserve the posterior element structure. It wasn't until 1981 that Hirabashi introduced the unilateral open door laminoplasty, which is the current practice that we have today in most cases. The unilateral open door laminoplasty is how we often perform laminoplasties here at Mount Sinai and in many centers across the country. And he published these results in spine, which we can see in these old photographs here, which have two main benefits. The first is for multisegmental decompression with preservation of the posterior structural elements while preventing postoperative kyphosis and segmental instability. Now, since Hirabayashi has published this, there have been a lot of revolutions in terms of technologies, implant design, et cetera. There are many options for how to hinge a laminoplasty. There isn't one correct way per se. People have tried wires. Similar technique has been done in scoliosis and deformity cases. They've used autograft bone graft from fibular struts. They've used mini plates, which is what we commonly do here at Mount Sinai. But just especially for the residents and trainees, it's good to know that there are multiple iterations of laminoplasty. There's a French door laminoplasty, which was founded by Kurokawa, which is more of a dual hinge dual hinge technique where you split the spinous process over to make more room from the midline, which you can see on the figure on the right. Then there's also an open arch laminoplasty founded by Tomita, where the spinous process is cut and then the lamina is widened on the sides. So just pushing the limit as far as MIS and motion preservation surgery, Shirashi actually came up with this muscle sparing technique where the interspinous muscles are not cut, but simply split, and the spinous processes are divided. Then skip laminectomies are performed to do a double door laminoplasty. You know, I'm sure our head of MIS spine surgery would love this, but knowing Jeremy Steinberger, he probably wouldn't advocate for dividing the interspinous muscles. All right, so looking at cervical laminoplasty broadly, the objective is to accomplish goals of a laminectomy without all the drawbacks associated, which Abi mentioned. So it's for multi-level spinal cord decompression. However, unlike laminectomy alone, it does prevent significant scar formation over the dura, which can lead to subsequent complications. It avoids stabilization of the posterior elements by keeping them somewhat intact, and it allows preservation of physiological mobility as well as range of motion. Now, we'll just quickly get the residents involved because I know it's getting that time where people stop paying attention. So, Ziad, what do you think are some indications for laminoplasty?
I think obviously degenerative cervical myelopathy, as you mentioned, but from a patient perspective, patients need to have some sense of, or they must not have any axial pain because that would be treated more likely by fusion. So laminoplasty candidate must not have axial neck pain. Moreover, I think healthy sagittal alignment. If there's any sense of spondylolisthesis, you would more so opt for a fusion. And then also not being overly kyphotic to begin with, just because opening up that posterior element without being able to fuse or readjust the alignment won't really allow the spinal cord to drift back far enough.
Yeah, no, I think that's a great answer. I think you touched on many of the major points. So again, going back to Jeremy Steinberger, indications are everything, right? And you will see guys when you go into practice in the Midwest who are going to offer a C2 at T2 for all these patients. So there are specific indications for laminoplasty, right? Multi-level cervical stenosis, definitely one of them. Preserved alignment, I think, is key. And as Avi mentioned, a lot of the patients that fail laminoplasty are really for surgeons who are pushing the envelope there, and the patient may not have the best preoperative alignment. It's important. Now, do you necessarily need perfect lordosis to do a laminoplasty? No, which I'll talk about, but it's definitely preferred if the alignment is neutral or slightly lordotic. And then, as Ziad mentioned, you want the patient to have minimal spondylotic axial pain. If the patient's primary complaint is pain, you should probably think twice before doing a motion preservation surgery, as there may be some underlying instability. All right, now, probably even more important than the indications, there were some contraindications for laminoplasty. So, Mike Curley, can you give me any contraindications? We kind of touched on them. But what do you think?
Too much kyphosis, also like unilateral radiculopathy. I think like inflammatory arthritis is another contraindication. Axial neck pain, like C had mentioned.
Nice. Yeah, those are all great answers. So I think the first thing is gross instability on dynamic imaging, right? You have to make sure that these patients are stable. Significant kyphosis or loss of lordosis, I think, is really important, especially across the levels that you're going to instrument. And then, like you mentioned, the primary symptoms, spondylotic axial pain or pure radiculopathy, the patient may be a better candidate for a procedure like a foraminotomy or short segment ACDF, et cetera. Now, you did a great job mentioning that there are also some relative contraindications. One are inflammatory arthritis, such as rheumatoid arthritis, ankylosing spondylitis. These patients, you should probably think twice before doing motion preservation surgery. Some may be candidates, but many are not. And then patients with mild spondylolisthesis, you really have to measure on a patient-to-patient basis for these. So where's the evidence, right? Going quickly over the dogma of cervical myelopathy. So there are a subset of these patients who do have micro or macro instability leading to pathology, and these patients in general are poor candidates for motion preservation surgery. However, if the myelopathy is due to structural or static factors, such as a disc herniation, congenital stenosis, motion preservation may be a viable option. Now, just to quickly talk about the field of motion preservation surgery and DCM, as our group here at Mount Sinai has done some fantastic work on this in the past, and just to highlight the work done by John Hooten and Aaron Boylan with the great help of our medical illustrator, Jill Gregory, we looked at over 20 years of patients who received cervical disc arthroplasty in the degenerative cervical myelopathy population. And what we found is that it has a very favorable safety profile. And the majority of the studies in this meta-analysis found significant improvements in neck disability and JOA myelopathy scores post-op while effectively improving range of motion. So just broadly, there's been a great deal of evidence over the past couple of decades on the use of motion preservation surgery in DCM. Now, there are 5 major advantages that I want to highlight that were a few obvious points as far as why laminoplasty is the superior option. So one is faster recovery time, more favorable safety profile, motion preservation, as you mentioned, lower rates of hardware and adjacent segment failure, and then finally lower cost. All right, so I'm very briefly going to introduce some evidence for each of these points. So because Stephen Miranda hasn't been highlighted enough today, I just wanted to show a great paper that he wrote only this year, where he led a randomized clinical trial led by Dr. Gadawala that was published in the Red Journal this year. And it was a randomized controlled trial. It was a CSMS trial where patients were randomized receiving ACDF or posterior approaches, including both laminoplasty and posterior cervical decompression and fusion for DCM. Primary outcome was the PCS scores of the SF-36 at 1 year's post-op, and he looked at JOA, NDI, and quality of life scores. And the results I want to highlight are in the arrows here, in that at all 3 time points, laminoplasty and post-lami fusion patients were compared, and as you can see, at both 3, 6, and 12-month time periods, patients had optimal SF-36 physical component scores. And then if I could draw your attention to the Kaplan-Meier curve on the left, you'll notice that in terms of return to work, patients in the laminoplasty group actually returned to work even faster than ACDF patients, which was significantly higher than the posterior cervical decompression and fusion patients. And this trend and this relationship between lamina fusion and laminoplasty extended all the way out to 1 year. So Dr. Miranda and his group concluded that patients returned to work much faster after laminoplasty, with a mean time return to work of only 1 month compared to 6 months following lamina fusion. There are worse physical function disability scores after lamina fusion at 3 months, and lower SF36 scores, as well as higher NDI scores compared to both ACDF and laminoplasty. So in terms of how safe laminoplasty is, there has been a large body of evidence looking at the complication rates of laminoplasty as this procedure has become more widely accepted and used in North America in the past, say, 10 to 20 years. Baker et al., which is a group at UC Davis, found that the short interval wound complication rate with lamina fusion is actually double the rate of laminoplasty, with a risk ratio of over 5. Darrell Lau, when he was at UCSF, studied these patients long term, and a paper published in the White Journal found that there was over a 5-time increased rate of long-term complications overall in lamina fusion compared to laminoplasty. There's a little less than half of the amount of EBL as expected with laminoplasty compared to lamina fusion. And then Dan Rue's group about a decade ago found both a lower infection rate and reoperation rate in laminoplasty when compared to lamina fusion patients. Highsmith found that PCDF doubles the rate of complication compared to laminoplasty. And then what's interesting, just going off our theme of peripheral nerve, is a big question has been the incidence of C5 palsy. And really the truth is it's inconclusive in the literature. Many spine surgeons believe that the C5 palsy rate is higher after lamina fusion compared to laminoplasty because it's the effect of the spinal cord flowing a little bit further back because there's no posterior tension band. However, these results haven't borne out truly in the literature. There are some large series showing that there are lower rates of C5 palsy in laminoplasty compared to ACDF or posterior cervical decompression and fusion. However, again, it's not consistent across the literature. Now, in terms of motion preservation, I feel like I don't have to do much to convince you that laminoplasty is a better procedure for motion preservation compared to lamina fusion, but just to be a little bit rigorous for a second, when looking at the actual biomechanics of the two procedures, as you would expect, there's increased stress with neck flexion, extension, axial rotation on laminectomy and fusion, which is obviously the goal of the procedure, right? It's an arthrodesis. Lamina fusion, it does reduce the stress with extension, lateral bending, axial rotation, then look at both stress and strain. And then, but something to consider with any biomechanical study like this is they only look at the instrument levels, right? And so something that a study like this did not include is that you have to look at the increased levels of strain placed at adjacent levels to your fusion, right, to your arthrodesis. And so this is something that laminoplasty addresses that is not, that obviously is a big stressor, no pun intended, in lamina fusion. Okay. Next, we're going to look at the rates of hardware and adjacent segment failure. So in terms of adjacent segment disease, we know this has been very well demonstrated in the spine literature that the length of the construct affects the rate of adjacent segment disease due to the greater biomechanical forces, creates this lever arm effect on the rest of the spine and the adjacent levels. So fusion procedures may have longer constructs. Something to consider is if the patient needs to be decompressed to say the level of C6 or C7, many spine surgeons will often cross the junction as they're hesitant to end their instrumentation at a junctional level. So this may lead to spine surgeons performing a larger procedure on more levels with a fusion as they would compared to a laminoplasty. We know that tissue disruption aids in adjacent segment disease development. This is something that Larry Lenke and other deformity surgeons have widely publicized in terms of muscle sparing surgery and how you want to minimize disruption to the posterior tension band in terms of affecting later on adjacent segment instances. And so violation of the paraspinal muscles, as well as the facets as seen in posterior cervical decompression and fusion, definitely affects this. And the truth is the rates of adjacent segment disease in PCDF are actually very high and probably higher than often reported and that we quote as surgeons. If you look at this study by Yaps a couple of years ago, they found that lamina fusion patients had adjacent segment issues in up to 38% of patients, and 30% of these patients had adjacent segment issues within 2 years of their surgery. Now, in terms of pseudoarthrosis rates, obviously this is relevant in the fusion population. A study done by Yoon about a decade ago found a 38% of pseudoarthrosis rates. Granted, not all of these are going to be clinically significant and warrant reoperations, but this is something to consider that is exclusively an issue in the fusion population, as pseudoarthrosis rates in the laminoplasty population is not really commonly seen or reported. Overall, both these procedures do have relative low revision rates. So even though up to 38% of these patients may have a radiographic pseudoarthrosis, Kevin Hines and Jeff published a 4.8% revision rate in symptomatic pseudoarthrosis or adjacent segment issues in patients with lamina fusion. However, if you compare it to the laminoplasty literature, Hashimoto published a series a couple of years ago, and he had to track his laminoplasty patients all the way out to 26 years before he can get to a 1% revision rate. Right? So it's kind of hard to compare those two groups, in my opinion. And then finally, we're going to end with the money. So talking about cost effectiveness. So I like to break cost effectiveness down into two groups when thinking about a spinal procedure. One is the patient factors, and the second is the hospital factors, because this is ultimately what drives our business and drives our practice. So in terms of patient factors, again, going back to Steve's study, so in terms of the economic impact of laminoplasty versus posterior cervical fusion, if both patients are a candidate, it's hard to compare someone returning to work in 1 month than someone returning to work in 6 months. If you're talking about inpatient rehab stay and the global economic impact of that procedure, I think it's surmountable. The surgery costs are much lower when just talking about the actual index surgery. I know Abhi brings up the idea of revision, though, as I mentioned in my prior slide, having to track patients out to almost the age of some of our residents to get to a 1% revision rate, I feel like that's not really a relevant argument. And the surgery of laminoplasty versus posterior cervical fusion, as far as what the cost is, what the patient sees, is around 50%. Granted, this was a study published a decade ago. Even though these numbers today are going to be higher, I believe the trend still exists today. And then looking at some hospital factors, the implant costs are something that the hospital is always keen about and discusses with surgical leadership and how much we're spending on implants. And so if we can perform the surgery with the same objective with 1/3 of the implant costs, I think that's something that we have to consider. Highsmith, granted, the study was a decade ago, found that laminoplasty on average, surgeons spent $4,200 on implants compared to $12,000 for the average lamina fusion. Again, these numbers are going to be elevated now, but it's still a significant disparity. There was a recent study by Chua that found that there's significantly lower facility costs associated with laminoplasty. And the overall lower hospitalization costs. Patients stay in the hospital for less days, they return, their readmission rate is lower. All of these factor into a lower overall hospitalization cost of less than 50%. And again, I mentioned the decreased length of stay. And just something interesting, I know this is true, Dr. Marguez' heart, and something he loves to teach the residents about, is there are significant differences also in terms of surgery reimbursement for laminoplasty versus lamina fusion. Part of it is because for a laminoplasty, you're not billing for both the arthrodesis as well as the instrumentation. You're just billing for the instrumentation. So it is less RVUs, but again, ultimately it matters on what the patient benefits from. So as far as take-home points, again, as Jeremy says, indications are everything, and especially in the surgical management of cervical myelopathy. So going back to Abhi's take-home point, laminoplasty for every patient with multi-level stenosis causing myelopathy is not good clinical practice. I think we can all agree on that. However, I would counter with fusion for every patient with myelopathy is probably not necessary and could come for further risk down the line. So for the right patient, as Jeremy says, laminoplasty can be a total home run. In conclusion, there's a fast post-operative recovery. Patients return back to work quicker, they're happier. It's a cost-effective procedure both for the patient as well as the hospital. It offers a low complication rate and very high patient satisfaction. Now, ultimately, you have to think about if this was your neck, right? Would you want to look like the person on the left or the person on the right? Or to put in more blatant terms, would you rather look like this or look like that? Thank you guys for your time.
Great job, Abhi and Alex. Alex, I have nothing to say because you took everything you said I would say is what I was going to say. But I think for me, I'll tell you my own personal journey with laminoplasty is it's only gone up over time. Certainly for someone who has great lordosis and multi-level stenosis and no neck pain is just the home run. And then I'm even pushing it into, you know, maybe like a stable grade 1 spondylolisthesis, which is, you know, debatable for sure. And the counterpoint is easy to make on that case, or even someone with a neutral or slightly kyphotic neck, especially if they're elderly. So I think finding indications, but I do think that laminoplasty is an amazing surgery, but for the right patient. I say that as somebody, by the way, who I technically do not enjoy doing laminoplasties. It's Khan's favorite surgery. It's my least favorite surgery. Halima's laughing because we had a tough one together. I still remember it. But it's finicky and it's a little, but the more you do it, the better you get at it. And it is a great option for patients.
Yeah, I'd like to chime in. Great job, both of you. It is a tough topic because it's not one winner, right? It's not that every case is better for one or the other. Those of us who do a lot of this have our own viewpoints on it. I will say that as someone who didn't train with a lot of laminoplasty, I have seen the value and the growth. It's interesting to, when you go to these meetings, you talk to people who are senior people in the field, like Ed Benzel and others. They have, over time, gradually evolved more and more to laminoplasty. And so I do think that there is a trend towards laminoplasty, and I think that there's some valid reasons for it. I just think that you can't generalize that one is better for the other. We see plenty of cases where the laminoplasty didn't work as well as it should, and then we even have conversion. Obviously, you can't convert from a fusion to laminoplasty, but there are cases of adjacent segment. I think those numbers that Alex presented are interesting, but I don't think they're representative. Having done 24 years of posterior cervicals, I don't see a 30% adjacent segment rate degeneration like we do in the long posterior deformity cases. So I will say that in closing that both of you did a great job, and both are tools that we need to have in our spine surgeon toolbox. Thanks.
I'm happy to chime in. Hope it's not loud where I am, but thanks for the shout out, Alex. But yeah, great job from both of you. I do just want to point out for that trial. I mean, it's an interest. I believe even Dr. Chowdhury was involved in recruitment for it. So good representation there from Sinai. But the important thing about that study was that it was about the equipoise population, like you mentioned, that they had good alignment and patients could be randomized either to anterior or posterior. But that was a post hoc analysis. The posterior group between laminoplasty and PCDF was not randomized. And so I believe the next trial they're doing is to look directly at that laminoplasty versus fusion, all fusions, anterior versus posterior. So I think it'll be really interesting to look at that trial. But yeah, you're absolutely right. The signal in there, despite the small numbers, is that those patients did better. So it's really interesting to think about for the right patient that it's a better operation. And we do have some data that in that trial itself, that laminoplasty was more cost effective. So great job highlighting that. I think it has a big population effect.
All right. Great presentations from everybody. And if there are no more comments, I think we'll wrap. All right. Thanks a lot, everybody.